Right now, clinics everywhere are marketing these vaginal rejuvenation lasers as like a quick 15-minute fix. You walk in, sit down, a device does its thing, and you leave with your post-childbirth laxity or your menopause symptoms just completely resolved. But what happens if your body's genetic blueprint for healing is fundamentally broken?
Well, it creates a massive biological collision. I mean, we are taking this cutting-edge aesthetic technology, which assumes every single human body heals in the exact same predictable way, and we're applying it to profoundly individualized biology.
Welcome to the deep dive.
Mm.
Today, we are exploring a highly targeted, really fascinating question that came up in our research stack. Does having hypermobility, or a connective tissue disorder, make the results of these popular vaginal tightening procedures less predictable or even dangerous?
Yeah, and to answer this, we're looking at a pretty diverse array of data. Our sources today include FDA safety communications, European and British gynecological guidelines from NICE, and multiple clinical studies on energy-based devices. Plus, we have some emerging research from specialized clinics, focusing specifically on Ehlers-Danlos syndrome and hypermobility spectrum disorders.
Right, and we are putting all these pieces together because this is a puzzle the medical field is really just starting to formalize. And here is the core tension for you to keep in mind as we go through this. The entire, booming industry of high-tech vaginal rejuvenation relies on one single biological mechanism.
Right, triggering the body's natural wound healing response.
Exactly. And we are going to look at what happens when that specific response is genetically altered. Okay, let's unpack this.
So before we look at the disruption, we really have to establish the baseline. It helps to understand how these procedures are actually supposed to work in a typical non-hypermobile body. When we talk about energy-based devices in the gynecological space, we are primarily looking at two distinct categories: radiofrequency and lasers, specifically like CO2 and erbium YAG lasers.
Just to set the visual here, we are not talking about a surgeon with a scalpel. This is entirely non-surgical.
Oh, absolutely. There are zero incisions. Instead, these devices use highly calibrated heat or light to intentionally create controlled damage in the tissue. Take radiofrequency devices, for example.
Okay, how does that one work?
Well, they deliver electromagnetic waves into the tissue, heating the underlying layers to somewhere between 40 and 45 degrees Celsius. At that specific temperature, the triple helix structure of your existing collagen fibers literally denatures. It just folds and contracts.
Wow, so that contraction provides an immediate mechanical tightening effect. But the heat isn't just about an immediate shrink wrap effect, is it? It's about what happens over the next few weeks.
Yeah, that is the long-term goal. Lasers operate on a similar principle but use light to target the water inside your cells. When a fractional CO2 laser is used, it fires tiny, pixelated collars of light into the vaginal mucosal lining and the connective tissue right beneath it.
And we call it fractional because it doesn't just burn the entire surface.
Right, it leaves microscopic pillars of healthy tissue in between the tiny thermal burns to speed up recovery.
So the device is intentionally injuring the patient. That's the whole point.
The injury is the entire point. The cellular goal is to trigger an acute inflammatory wound healing cascade. When your tissue registers that thermal damage, it sends out chemical distress signals.
And in response, your body dispatches specialized cells called fibroblasts to the area. I love visualizing this stuff. So if we look at the vaginal canal like a house, it sounds like a forced home renovation.
I like that analogy.
The laser essentially knocks down a few walls. Those are the microscopic thermal injuries. And that forces the body's construction crew, the fibroblasts, to show up on site.
Yes, and once they are there, they realize they need to build a stronger, newer structure in its place.
That captures the process beautifully.
The fibroblasts arrive at the site of the thermal damage and immediately begin synthesizing brand new collagen and elastin proteins. In medicine, we call this neocollagenesis. And simultaneously, they stimulate the growth of new blood vessels, bringing more oxygen and nutrients to the area.
So theoretically, over the course of 3 to 6 months, this renovation creates thicker, tighter, more resilient, and more naturally lubricated tissue.
Exactly.
We should definitely note that, based on the clinical guidelines in our SAC, these devices aren't just being marketed for cosmetic vanity. They are being used to treat genuine, debilitating quality of life issues.
Oh, definitely.
We are talking about genitourinary syndrome of menopause, which causes severe tissue thinning, dryness, and pain. Or stress urinary incontinence, where a patient might leak urine when they sneeze or laugh.
Right, and of course the natural vaginal laxity that occurs after carrying a pregnancy or just going through the aging process. For the patients experiencing these symptoms, the daily psychological distress and physical discomfort are
It's
profound.
life-altering.
It really is. So, the appeal of a quick, non surgical laser treatment that you can do on your lunch break is entirely understandable. If the fibroblast construction crew does its job exactly as expected, the results can genuinely restore patients' quality of life.
But here's where we hit that biological collision.
Yeah.
What if the construction crew is working with a fundamentally flawed set of blueprints? This is where hypermobility enters the picture.
Yeah. Hypermobility spectrum disorders and Ehlers-Danlos syndrome, commonly called EDS, are inherently disorders of connective tissue. And connective tissue isn't just in your joints.
Right. It is the scaffolding of your entire body. It holds your organs in place, it makes up your skin, your blood vessels, and heavily makes up the structure of the pelvic floor.
And in EDS, the genetic instructions for building collagen are mutated.
The sources from the specialized clinics explicitly state that even benign joint hypermobility syndrome can cause vaginal tissues to become severely stretched and lax over time, just from normal life events like gravity or a single childbirth.
The levator muscles and the deep endopelvic fascia essentially form the structural hammock of the pelvis. In a hypermobile body, that hammock is inherently overly stretchy and fragile. It just does not possess the elastic recoil of typical tissue, so once it is stretched, it struggles to bounce back.
Okay, I have to stop you there and push back on this logic, because honestly, this sounds like a massive medical paradox. Well, if hypermobile patients have weak connective tissue and they lack good, tight collagen, and these lasers literally exist to stimulate the body to make more collagen, shouldn't a radiofrequency or laser device be the absolute perfect cure for them? Just fire up the device, stimulate massive neocollagenesis, and fix the laxity.
It is the most logical assumption a doctor or patient could make, and it's exactly why this intersection is so incredibly tricky. But the underlying biochemistry tells a completely different story.
Because the blueprint is broken.
Right. Because the fundamental genetic blueprint for the collagen is flawed. When that thermal laser triggers your construction crew to rebuild those knockdown walls, the fibroblasts are still pulling from the exact same faulty materials. You are demanding more collagen, yes, but the body can still only produce fragile, disorganized, hypermobile collagen.
You're just forcing them to build a brand new wall using the same crumbly bricks.
That is a critical piece of the puzzle. But the cellular environment in a hypermobile body makes it even more complicated. Many patients with hypermobility and chronic illness deal with systemic low-grade inflammation.
Okay.
Their extracellular matrix, which is essentially the fluid ocean that all these cells live and communicate in, is constantly stressed. And a major part of that inflammatory state involves enzymes called matrix metalloproteinases. They are usually abbreviated as MMPs.
Matrix metalloproteinases.
Hmm.
With a name like that and the fact that we're talking about inflammation, it sounds like they are actively breaking down the cellular matrix. Are they like dissolving the tissue?
They are the body's demolition crew.
Yeah.
MMPs are enzymes responsible for clearing away old damaged proteins so new ones can be built. In a typical healthy body, their activity is highly regulated.
But in a hypermobile body.
The emerging research notes that under the chronic mechanical and inflammatory stress seen in EDS and hypermobility, these MMPs become hyperactive. They are constantly turned on, aggressively breaking down structural proteins faster than the fibroblasts can actually replace them.
Let me make sure I'm picturing this correctly. If a hypermobile patient gets this laser treatment, they have a slow construction crew trying to rebuild a wall with crumbly bricks, while a hyperactive demolition crew is actively smashing the bricks at the exact same time.
That is the reality of their extracellular matrix. Now take that incredibly stressed, fragile, disorganized tissue environment and introduce a 40-degree-Celsius thermal burn to it.
Oh, wow. If the body is already destroying its own tissue faster than it can rebuild, hitting it with a laser isn't just ineffective, it sounds actively dangerous. Are we seeing actual clinical harm from this?
We absolutely are. The standard clinical assumption is that a fractional microinjury yields a predictable, uniform tightening response. But in hypermobility, introducing thermal trauma creates profound unpredictability. It might not yield tightening at all.
What happens instead?
It frequently results in delayed wound healing, excessive inflammatory storms, or highly abnormal scarring.
Which brings us to the actual regulatory stance on this.
Yes.
The FDA has actually sounded a massive alarm. Back in July 2018, they issued a very aggressive safety communication.
Yes, they did.
They explicitly warned against using energy-based devices for vaginal rejuvenation. They stated these devices are not approved to treat symptoms like vaginal laxity or pain during sex, and that they carry very serious risks.
To understand what those risks look like in practice, the overview from NICE, the National Institute for Health and Care Excellence in the UK, documented some intense real-world complications. One case study involved a 68-year-old woman suffering from severe vaginal dryness and pain.
Right, I read that one.
She underwent 3 courses of a fractional CO2 laser. Afterwards, instead of rejuvenated elastic tissue, she developed a crescent-shaped fibrous band in the middle of her vaginal canal. It physically impinged on the space, creating a stricture and a partial obstruction.
Wait, a physical obstruction, why does that happen? If the laser is supposed to make smooth elastic tissue, why did her body create a physical blockage made of scar tissue?
It comes back to how disorganized the healing process becomes. In a typical body, the fibroblasts lay down a neat, flexible lattice of collagen. But when the healing blueprint is chaotic or the tissue is inherently fragile, the inflammatory response panics.
So you just flood the area with whatever they can.
Exactly. The fibroblasts dump massive amounts of disorganized, rigid collagen to quickly patch the thermal burn. That disorganized collagen hardens into thick, restrictive fibrotic bands rather than smooth, stretchy mucosa.
That sounds excruciating. And looking at the rest of the NICE report, that crescent band was not an isolated incident. Other patients experienced persistent, progressively worsening dyspareunia, which is severe pain during intercourse, along with something called pelvic floor hypertonus.
Pelvic floor hypertonus is a condition where the deep muscles of the pelvis become locked in chronic, incredibly painful spasms.
Why do the deep muscles spasm if the laser is just on the surface?
Because the superficial tissue has been traumatized by the heat and is healing abnormally. The deeper muscles contract to guard the area against further pain or microtearing. They just lock up and refuse to release.
When you lay out those specific complications, abnormal fibrotic scarring, strictures, and extreme tissue sensitivity leading to muscle spasms, that sounds alarmingly similar to the exact risks hypermobile patients already navigate every day with general wound healing.
It does. It highlights a massive gap in patient screening. Consider someone with classical or hypermobile EDS. They are already inherently prone to atrophic scarring.
Those are the wide, sunken, papery scars you often see on their knees or elbows from minor scrapes. Right?
Yes. Their tissue tears easily, and they experience abnormal wound healing from basic, everyday injuries. If that is their baseline, introducing a deep thermal burn or an ablative laser to their most delicate, hormonally sensitive mucosal tissue is a monumental gamble.
It's like pouring gasoline on a fire that you were trying to put out. So if energy-based devices, which only target the surface level anyway, are this unpredictable and potentially dangerous for hypermobile bodies, what is the alternative?
To find the alternative, we have to look at what is actually causing the laxity or the pain in the first place. Dr. Michael Lau, a surgical expert cited in our sources, makes a critical distinction between superficial tissue and structural support.
Right. He argues that energy devices like lasers and RF only penetrate the superficial mucosal lining and a few millimeters of the very shallow underlying tissue.
Exactly. But vaginal childbirth, or the chronic lifelong strain of severe hypermobility, doesn't just stretch the surface skin. It physically damages and stretches the deep fascia and the levator muscles holding the organs up.
That is deep structural anatomical damage. I mean, you can't fix a structural muscle separation with a superficial surface burn.
No, you can't. For true structural repair, surgical experts point to a procedure called vaginoplasty. This is a reconstructive surgery where a surgeon physically dissects the area, removes the excess stretched tissue, and uses sutures to pull the deep muscles and fascia back together.
Restoring the original anatomy of the pelvic floor. But hold on, if we are talking about a patient with EDS, surgery can't be a magic bullet either. I'm thinking about this structurally.
It isn't a magic bullet, no.
It's like trying to anchor a heavy picture frame into drywall without a stud. You can put the surgical screw in, but the second the weight of the pelvic organs is applied, it's just going to rip a bigger hole in the fragile wall. Won't the stitches just tear out?
You've perfectly articulated the exact surgical dilemma doctors face. Surgical vaginoplasty in EDS patients has a notoriously higher failure rate for that precise reason. The tissues they are suturing are inherently weak.
Do surgeons have a workaround for that?
Surgeons often compare it to trying to stitch together wet tissue paper. They have to use extreme caution, highly atraumatic surgical techniques, and sometimes leave supportive sutures in place much longer. And even with all those precautions, the mechanical laxity can recur over time.
Because gravity never stops pulling on that weak connective tissue. That has to be incredibly frustrating for the patient. You can't use the laser because of scarring. and surgery might just rip out.
It is extremely frustrating.
But as I was reading through the clinical data in our stack, I noticed a really fascinating nuance regarding emerging treatments. While destructive energy, like the lasers creating thermal burns, might be highly risky, there is a whole other category of regenerative therapies being actively tested for EDS.
The distinction between destructive and regenerative is vital here. Destructive therapies rely on traumatizing the tissue to force the body to mount a massive healing response.
Right.
Regenerative therapies take a completely different approach. They aim to directly supply the body with the materials or chemical signals it needs to heal without causing that initial massive trauma.
What does a regenerative therapy actually look like in practice for these patients?
One major area of exploration is platelet-rich plasma, or PRP. A doctor draws the patient's own blood, spins it down in a centrifuge to isolate and concentrate the platelets and growth factors, and injects it directly into lax ligaments or injured tissue.
Okay, so instead of burning the tissue to sound an alarm and wait for the body to send the construction crew, you are helicoptering the crew directly to the site, fully equipped.
That is a great way to put it. In hypermobile patients, PRP and prolotherapy, which involves injecting a mild irritant to provoke localized ligament stabilization, are being used experimentally to strengthen loose joints, particularly the sacroiliac joint in the pelvis.
And since the sacroiliac joint is intimately connected to the pelvic floor, the implications for treating vaginal laxity and prolapse are huge. But I have to bring up the most confusing thing I found in the sources.
What did you find?
There was a dermatology case study where a doctor actually did use an ablative laser-like, a severe laser, that completely removes the top layer of tissue on a patient with hypermobile EDS to treat some severe scars. And it worked.
It did work.
Wait, after everything we just discussed about how thermal trauma causes massive fibrotic scarring and inflammatory storms in EDS, you're saying a doctor used the most aggressive type of laser on an EDS patient and the scars improved. How does that not completely contradict everything we just established? How does a laser suddenly work on a genetic defect?
It sounds completely contradictory until you look at the specific biochemical intervention the doctor used alongside the laser. They didn't just use the ablative laser.
Oh, they did something else.
Yes, they immediately followed the laser treatment with an application of high-dose topical vitamin C directly into the open microwounds.
Okay, so how does a topical vitamin override a genetic collagen mutation?
Vitamin C is a mandatory cofactor for collagen synthesis. Specifically, it is required to cross-link the collagen fibers. Without adequate vitamin C, the collagen fibers can't weave together to gain tensile strength.
So they remain weak and disorganized.
Exactly. The biological theory in this case study is that by providing a massive localized dose of the exact nutrient the fibroblasts were starving for right at the moment of injury, they fundamentally altered the local wound healing environment.
So they knocked down the wall, but instead of letting the crew use the usual crumbly bricks, they backed up a truck and handed them a load of high-quality fortified cement.
Precisely, they changed the biochemical materials available to the cells. But we have to emphasize heavily that this was a single case report on external skin scars, not the internal delicate mucosal tissue of the vaginal canal.
Right, which highlights just how experimental, nuanced, and wildly unpredictable this space truly is. What works brilliantly for a typical patient could permanently scar an EDS patient.
And what might eventually heal an EDS patient requires a completely customized, deeply complex biochemical approach that standard cosmetic clinics simply do not offer.
If you are sitting in a clinic waiting room right now, filling out an intake form for one of these procedures, this is why checking that little box for hypermobility or connective tissue disorder changes absolutely everything.
It really does.
Vaginal rejuvenation is plastered on billboards and Instagram ads as a universal quick-fix procedure for everyone. But your biology is profoundly, radically individual.
A machine calibrated for the average population cannot account for your unique genetics.
If you have hypermobility, or frankly, any systemic condition that affects how your extracellular matrix behaves, your body responds to injury, heat, and inflammation in highly unpredictable ways. That makes standard, off-the-shelf collagen-stimulating treatments a real gamble with your pelvic health.
Definitely.
So what does this all mean for you? Understanding your own underlying physiology, your personal structural scaffolding, is the absolute most crucial step before you ever allow a device near your body.
If we look ahead, the unpredictability of these devices in hypermobile patients raises a massive question about the future of aesthetic and reconstructive medicine. If our connective tissue dictates everything from our joint stability to how our pelvic floor heals from a simple laser burn, could the future of this industry require a genetic or connective tissue screening before a doctor even considers picking up a laser?
Wow, just routine genetic screening before a cosmetic procedure.
Exactly. We might be rapidly entering an era where your hypermobility score is just as important as your blood pressure before clearing you for a cosmetic procedure.
That completely flips the current marketing model on its head. Right now, the industry treats every patient like they have the exact same blueprints. The more we demand personalized medicine and the more we understand the mechanics of our own tissue, the safer these interventions will become. Thank you so much for joining us on this deep dive. Keep questioning those one-size-fits-all medical promises, respect your body's unique scaffolding, and we'll catch you next time.